pretty easy for these guys to silently obstruct and die, and you wouldn't even notice if you didn't have somebody actually in that room, actually watching the patient really actively. Then they'll die pretty quickly, and I would say that they would die within 5 minutes.
Hi, I'm Hubert.
This is Gerardo.
And I'm Dr. Bronwyn Fullagar. I'm a specialist small animal surgeon based in the Canadian Rocky Mountains.
And you are listening to the Vetwelt Clinical Podcast. Hello Vetwelters, welcome back and Happy New Year. We wanted to share one of the episodes with you from our clinical series of podcasts to give you an idea what they are about. This one is from a series we did on brachycephalic obstructed airway syndrome, i.e. squishy-faced dogs who can't breathe, with specialist surgeon Dr. Bronwyn Fullagar and Dr. Mark Tenenbaum, who is a GP vet who works in a practice that has a strong focus on helping brachycephalics. Regardless how you feel about bulldogs and their flat-faced friends, the reality is that you will have to deal with them. This episode is from our surgery series, but don't be put off if you're not the surgeon who'll be doing upper airway surgery. There is a lot of value here for any vet around general approaches to dealing with the brachys in hospital, from safe handling and sedating all the way to waking them up and managing them post-op for any surgical procedure, not just airway surgery. If you want to hear part 1, 3 and 4 of the BOAS series to learn more about the pathophys of BOAS, how to decide which ones need surgery, how to assess them for surgery, what can go wrong, how to actually do the surgery, and much, much more. And if you want access to the summarized show notes that you can refer back to later, then we'd love you to check out the Vetwelt Clinical at vvn.supercast.tech. That's VVN for Vetwelt Network, or click the link in our show notes. Okay, over to Drs. Bronwyn and Mark. Enjoy. Last time we talked about brachycephalics and their airways and how we make our decisions around surgery with them. But today I want to zoom out a little bit and look at how we manage brachycephalics in hospital, whether it is for airway surgery or any other surgery, really. What talk about the risk with these guys and how do we manage that? So I want to kick off with the first thing is when during that process, from the moment you admit a bulldog in hospital to when it's healed and everything's fine again, when are they going to die? What are the periods that we worry about most? If things are going to go wrong, what are the highest risk periods, Bronwyn? Is there research on it? What do you guys find in practice?
Yeah, I think there's 2 major risk periods. One of them is having a bulldog or a brachycephalic dog who's stressed in the hospital. So this is a dog that's, come in and either been admitted or been brought into the treatment area for anything really, anything from a nail trim to an x-ray to just a regular physical exam. And it's quite common for brachycephalic patients to become increasingly stressed. And unlike mesocephalic dogs or regular face dogs, when these dogs become stressed, they become, a lot of them need to breathe through their mouth, and so they start panting, and as they pant they generate lots of negative pressure in their upper airway, and that leads to edema and swelling and collapse of the upper airway, and then pretty rapidly can progress through to upper respiratory obstruction or complete respiratory failure. And it can happen surprisingly fast. And so I think one big thing is identifying a brachycephalic dog that's getting a little stressed or anxious in the hospital and immediately dealing with that. So in some cases, it can be as simple as, let's just take this dog back to the owner, put them in a cool exam room and let them settle down for a minute. And in other cases, it might be sedating that patient, putting them in a quiet space, providing them with a little bit of oxygen and trying to reverse this cycle of airway inflammation and airway obstruction. So I think that applies to really any brachycephalic patient in the hospital.
And that's not just post-op, that's even pre-op.
No, that's pre-op. I mean, fortunately, it hasn't specifically happened to me, but there certainly have been cases where a dog comes in for something completely unrelated, an x-ray of their knee or even a blood collection or a nail trim or something like that. And it's been a hot day, the dog's had a car trip, and before you know it, especially if people who are less experienced maybe with bulldogs are handling the patient and they don't see the warning signs, these patients can even die in the worst cases from a really simple procedure just because of this cycle of airway inflammation and stress. So that's kind of one risk period that doesn't necessarily have anything to do with surgery. And then I think the second risk periods are the peri-operative period. So immediately pre-operatively at the time when you've sedated your patient, but you haven't yet intubated them. That's a time when brachycephalic dogs, if they're heavily sedated, aren't able to maintain active opening of their oropharynx. So a lot of these dogs, in order to breathe, usually have to actively contract the muscles of their oropharynx to keep their airway open. And as soon as we sedate them, that area relaxes and they can obstruct and silently go into respiratory arrest. Many of them also regurgitate, so they can regurgitate and develop aspiration pneumonia before you've had a chance to intubate them. And then same goes for the post-operative period. Hopefully everyone's fairly familiar with waking up brachycephalic dogs from anesthesia. We want them to be quiet, not stressed, intubated for as long as possible, preferably until they're up and almost walking around the room with their endotracheal tube in, and then being closely monitored for airway swelling and aspiration. And then having equipment and staff on standby for these patients in the ICU or in the hospital. So endotracheal tubes, an induction agent, and a laryngoscope right by their kennel, so that if somebody does notice that they're having difficulty breathing, it can be immediately addressed in an instant.
Okay, cool. Mark, have you guys had problems? Have you seen stuff go wrong or almost go wrong?
Yeah, certainly. I think all those points are the risk periods that Bronwyn's mentioned. And I think for us, the one we are most keeping a real close eye on is the post-operative and the initial post-operative. It's when they're waking up is their stress. And I think if a dog wakes up, they've already got some airway inflammation from the surgery, and all they need is a bit of stress, start breathing a bit, start freaking out, and that swelling just closes over that airways. For us, that's probably our highest risk period where we really keep a close eye. We've got a much closer eye on them and ready to jump in if we need to.
It's interesting you talk about the stress, Brian, in emergency. We'd often see that dogs, the brachys come in for a mild heat stroke. So we're not talking about the actual boiled heat stroke, but just when they start getting upper respiratory distress on a hot day, and they start swelling closed from that that they do. And then you treat them, and then it's a couple of hours in and they're fine, and they wake up from, because most of them need to be knocked out when they come in to intubate while you settle things down, and they go really well. And then an hour or two while you're waiting for the owner, the bloody things get stressed in the cage again, and they start panting because they're stressed, and you hear them go from normal panting to and then they go blue again. You go, oh, you're kidding me. So that stress really does get them. So we know these things go wrong. Obviously most bulldog owners or brachycephalic owners are pretty aware of the risks as well, but do you handle the client differently in terms of how you prep them for the surgery? Mark, I'm going to go with you straight away. Do you have different consent forms and things like that? How do you set things up with them?
Yeah, no, certainly. The biggest thing here is the chat beforehand, which, yes, we do have a tweaked consent form that basically says, go ahead with whatever needs to be done, because as you know, we only know what we're dealing with once we actually in there having a look. So we have consent forms that write up exactly what the owners are comfortable with us doing or not doing. And we also have a consent form about the need for intranasal oxygen, a track tube, or what we describe as high risk care, which comes into your CRIs and which we'll discuss, and things about managing them post-operatively. So we discuss that, but the main thing apart from the consent form is the pre-admit discussion, or when we talk to them first a bit about BOAS, and we talk about the risks, and we always talk about percentages, which we like to give them. And the general stats in Australia, this is specialists anywhere from dogs that are 8 months of age up until 10 years of age, is 17% will need intranasal oxygen for the first 24 to 48 hours after BOAS surgery. 7% will need a tracheostomy tube, and 1 in 200 don't make it through the surgery. We don't bluff it and fake it. We're completely serious. And we say that if your dog does need a track tube, not only does it change the outcome, but it's expensive. Yeah. And the price goes up, and they need sometimes emergency care. And I think that having that discussion beforehand, which is a half-hour discussion. Yeah. Then when it comes to the consent form, they're like, oh yeah, I know all about this.
Yeah, gotcha.
We don't specifically have a different consent form at our practice for brachycephalic dogs, although we've considered it, and the AVMA here in North America recently suggested that, but certainly have a really frank discussion with owners about peri-operative risks and complications and what exactly will be involved with their pet. We always keep brachycephalic dogs in hospital for at least one night after their surgery, so they have 24-hour monitoring and nursing care. And I always explain to owners that the risk isn't over once the surgery's over. They've got this sort of at least 24-hour, if not a little bit longer, period where they might be at risk of upper respiratory obstruction or aspiration pneumonia. There's so much information now on the internet. It's unusual for an owner of one of these breeds to never have heard that anesthesia is, most of them understand that anesthesia is more risky in their dog, even if they don't understand why. So it's
almost the opposite. You almost need to be able to reassure them that we can do it, because most of them are actually just too scared of having procedures done, because all they've heard is your dog's going to die under anesthetic. Now, Brian, we talked about the stress earlier and how you manage them, how you keep them calm before and after. We'll start with you, and then we'll ask Mark the same thing. Have you guys got any protocols, any sedation protocols? Or obviously trying to keep them in a calm environment. I want to say that goes without saying. But chemically, how do you keep them happy in hospital?
Yeah, certainly. So we do a couple of things. We tend to always operate our brachycephalic patients first thing in the morning, if possible. So if I have an upper airway surgery to do, I want that surgery to be done early in the day so that, one, the patient isn't sitting in the hospital stressing before they get their pre-med, and two, we've got a full team in the ICU ready and waiting for that patient to come downstairs, and then I'll be in the building for the rest of the day ready to do a temporary tracheostomy if needed. So everything's set up for that dog to, if anything happens, we're all here and ready for it. And, it's not the middle of the night or anything like that. In terms of drugs and medications that can be helpful, if dogs come in for their initial appointment and they're a particularly stressed little dog, then I'll often send home some trazodone anti-anxiety medication with their owner and advise the owner to give that 1 hour before they come to the clinic in the morning. Yeah. We've also got trazodone in the hospital, so we can give them that. It is an oral medication the day of surgery, but I don't think that increases the risk of aspiration in these patients. It's probably more important for them to be calm. I've heard of others using, in conjunction with trazodone, some gabapentin as well, as like a little cocktail for stressed brachycephalic dogs, and it does work quite nicely. So you want to have a dog that's sitting in their kennel waiting for surgery, that's breathing calmly, that you hopefully hear minimal respiratory noise, and the patient is sort of resting in their kennel. I guess I usually avoid giving heavy sedative medication until we're all ready to start with the procedure. So I avoid giving, dexmedetomidine, for example, until we're all ready and waiting to be monitoring that patient really closely. Because what I don't want to happen is for that dog to get really sedate and then close up their airway.
Yeah, of course. Yeah. Mark, what about you guys? Have you got any recipes?
Yeah, and I was actually going to ask Bronwyn, with the trazodone, do you give it a few days leading up to the surgery, or do you just give it that morning?
If the dog is stressed at home, then we can give it at home as well. But otherwise, usually you just need to give trazodone sort of an hour before an anticipated stressful event. So it's not a drug that needs to build up in the system over a number of days to be effective.
I think in our clinic, pretty similar. We use for our pre-meds the medetomidine and methadone, and we use half-dose medetomidine that we'd normally use. So we go a bit lighter on that. And we also use either metamide or Serenia as well beforehand, because of the potential for regurg or things like that.
You use one or the other, or do you combine them?
We used to use Serenia, but now we're using metamide, and we also sometimes will send them home with metamide. We used to, which we don't anymore, use Losec or omeprazole. It depends on the history of the dog and the history of regurgitation and things like that.
So why did you stop using the omeprazole? Do you know?
We weren't really getting a big difference for the post-op regurg, but maybe Bron would have more ideas on that.
Yeah, so it depends a little bit on each individual patient, but I always use prophylactic GI protective medication in any brachycephalic dog that's having any kind of surgery. In the dogs who are regurgitating fairly frequently prior to surgery, I'll start treating them with medical management, so usually omeprazole and sometimes also metoclopramide at home for 5 days prior to surgery. So omeprazole, it's a proton pump inhibitor, so it'll reduce the amount of acidity of the stomach. It won't prevent regurgitation by any sort of physical means, but if the dogs do reflux, it's less likely to cause esophagitis, whereas metoclopramide will kind of tighten that lower esophageal sphincter and hopefully prevent regurgitation. And then preoperatively, I'll treat them with injectable omeprazole, which in the North America is called pantoprazole. Yep. In the immediate preoperative period, and meropenem or Serenia at the same time. And then sometimes if they've been a frequent regurgitator, we'll treat them with a metoclopramide CRI. So metoclopramide has a pretty short duration of action, so it's more effective if you can give it as a CRI. And then to go home, usually I will send these dogs home with omeprazole and or metoclopramide tablets, depending on how much regurgitation they've had. But yeah, I think even the dogs that are not clinically regurgitating a lot at home, we just know that the bulldog and the brachycephalic population has a higher risk of reflux and aspiration, just as a general rule.
It makes sense to me to use it. I had listened to a talk once by a medicine specialist who said they dealt with a fair amount of esophageal strictures and burns post any surgery. And we're not talking brachycephalics, he's talking about any dog. And he says they are such a nightmare to deal with. He's to the point, he said that if he ever had to go back into general practice, he would put every single dog that's going to have surgery onto the omeprazole or something a day or two before and stay on it for 5 days afterwards, just in case they have a regurg. Mark, I want to go back to the metatomidine that you guys use. Is that as soon as they walk in the door?
No, it's not as soon. Again, as Bronwyn said, we also try and do, especially the high-risk BOAS in the morning.
Yeah.
But we only pre-med them when we're ready.
So this is not to keep them calm in the cage or something. It's just the actual pre-medication.
Exactly right. Whereas post-op, we do, and I'll have to get you the dosages as well for this, is a metatomidine CRI, which kind of to keep them, again, more for the high-risk ones or where we're concerned that they're going to stress out. And so we put them on a CRI afterwards. And sometimes now we're actually preemptively using the CRI.
I'd love to get that dose because in my mind, metatomidine is, it bombs an animal out, but that's obviously at the standard, I'm going to do a major procedure dose. How cooked are they? Are they just nice and chill? Are they still sitting up or are they just lying, calmly sleeping? Or what do they look like on that CRI that you guys use?
Yeah, no, they're pretty still alert, reactive, and we taper it. And it's not a long-term thing. It's just the initial, maybe hour or 2 hours after surgery that we want to make sure that they're recovering appropriately. But they're not bombed.
And is it just metatomidine or do you put anything else in there? Is there an opioid in? I suppose they're on opioids anyway for pain control, I'd imagine.
Yeah, we just use and I guess metatomin has is a pain relief on board as well. So it has, what is it, alpha 2. But we also have, whether we're using we use steroids, some we use Medicam. So non-steroidals, post-op relief for these dogs. Yeah.
That's a good question. Steroids versus non-steroidals. Bronwyn, is there a preference for you?
Yeah, so I'll routinely give the brachycephalic patients that are having airway surgery an anti-inflammatory dose of dexamethasone and induction as well, so 0.1 milligrams per kilogram IV. And that's sort of a prophylactic because it reduces the inflammation and the swelling and edema of the upper airway and reduces the incidence of the dogs having an upper respiratory obstruction. And I think that's fairly common in the specialty world, at least, to give a prophylactic steroid anti-inflammatory. It's less for pain relief and more to reduce swelling. Yeah. And then because I've given that single dose of dexamethasone, I'm not going to give a non-steroidal anti-inflammatory to those dogs. Yeah. Perhaps if I had a really, a dog where I'd done an airway surgery that wasn't super clinical and there was minimal swelling and the dog had also had some sort of other procedure and there was no history of regurgitation, maybe I would use NSAIDs, like non-steroidals. But usually I'll give the dogs at least 24 hours after surgery before I'll start non-steroidal anti-inflammatories at all, just in case in that post-operative period we need to give steroid anti-inflammatories. I never send the dogs home with prednisone or a steroid as a pain relief medication. If they've had a steroid, I'll send them home. If it's a really small dog, with oral buprenorphine, which can be absorbed transmucosally, or gabapentin, or you can use acetaminophen or paracetamol or combinations of that medication as well. It's obviously off-label, but it can be used for post-operative pain relief in dogs that cannot have an NSAID. I also just I can tell you guys too what we use for our pre-med. So we use in North America more commonly dexmedetomidine, which is very similar in action to medetomidine. It's just more potent. So the dose that we would use would be IV as a pre-med. And then generally we use a lot of hydromorphone, which is not as common in Australia because it's the most commonly available and most cost-effective opioid pain relief. But hydromorphone has it can make dogs vomit and it tends to make dogs pant. And so what I'll tend to do is give the dexmedetomidine induced with propofol or alfaxalone, and then once the patient has had their airway exam and they're intubated, at that point give them their hydromorphone so as to avoid a patient where you're trying to do an upper airway exam and they're either panting a lot or worst case vomiting. Okay, cool. So we'll kind of delay the opioid until the patient's intubated.
That's a good idea. I don't know what you use, Mark, but methadone's one of our most common opioids, and that can make them pant like crazy. So it's a good idea to hold that off.
Yeah, methadone has a less incidence of vomiting, which is nice. And then, for post-op pain relief, depending on the patient, we might use methadone or buprenorphine IV while they're in the hospital. And again, avoiding hydromorphone and fentanyl, just because of the panting, and in fentanyl's case, the ileus and the regurgitation potential. I tend not to put them on a dexmedetomidine CRI. I might use a microdose of dexmedetomidine as they're waking up if they're having a little bit of a anxious episode. So that would be sort of 0.5 to 1 microgram per kilogram of dexmedetomidine, really low dose, and I find that takes the edge off. And then treat them either with intermittent dexmedetomidine, low dose asapromazine, or once they're able to swallow and have a little bit of food, some trazodone again. But I think I would rather have these patients be alert, sitting up in their kennel, looking around, swallowing, because that enables them to control their own airway and use their own muscles to keep their airway open. I think if they're too sedate, that's when you can run into problems. So it's this very fine line between having the patient not stressed, but also not completely zonked. Yeah. One thing I would mention with brachycephalic dogs and alpha-2 agonists like medetomidine or dexmedetomidine is that brachys tend to have really high vagal tone to begin with. And so they can have, pretty profound bradycardia associated with alpha-2s. And so just being aware of that and monitoring it for it, and then being prepared to reverse it or use glyco as needed.
Okay, cool. Right. So knockdown and anesthetic maintenance, is there anything different there compared to other patients that you reserve for the brachycephalics? Or was that just a standard knockdown and intubate and ISO or whatever you're using?
I think if I'm doing only an airway surgery, so the anesthesia time is going to be quite short, I'll use propofol rather than alfaxolone. And this may be just an anecdotal experience of mine. I'm not sure if other people have felt this, but I find that dogs that have had a really short anesthesia with alfaxolone, when they're waking up from alfaxolone as opposed to waking up from isoflurane, if it's been a longer anesthesia, they can be quite panty and have a period of quite profound dysphoria. And that's not what I want in a brachycephalic patient. I'll use propofol because I feel like their recovery is smoother. That may just be my own anecdotal evidence. Both of them are safe.
How short is short? How quick is the surgery?
Like 20 minutes, half an hour.
Okay.
So the patients are still going onto isoflurane. Yep. They're still being intubated and they're on ISO on oxygen. But, or for example, if, we're doing an upper airway exam, but we may not do surgery, we're just looking at the airway and then waking up the patient, then that would be pretty quick as well.
Okay.
We'll talk about this, I guess, when it comes a bit at the procedure itself. But I know with our head surgeon, I think the laryngeal saccules, if they're everted, remove them before intubating. So that can just change a bit about maintaining almost on an IV anesthetic for that short period of time. It's a quick procedure, that part, but that kind of is a bit of an iteration to your standard one, and that's on the assumption that you're doing BOAS. So you do your quick airway exam and then correct appropriately. But if it's got everted laryngeal saccules and you are removing them, that kind of tweaks the protocol a little bit, but otherwise pretty stock standard.
Yeah, I do remove everted laryngeal saccules with the patient extubated. I think I've got into the habit of doing them second in line in the procedure after the soft palate, because I find that in some patients, by the time you've done your upper airway exam, maybe the patient hasn't been breathing great because they've just had some induction agent, or maybe they're mildly cyanotic or their SpO2 is not the greatest. I like to just get them intubated, get them on oxygen, improve their ventilation, and then do the soft palate. So they've had a nice period of time breathing oxygen, and then top them up with some induction agent, remove the saccules, and then re-intubate them. And then the endotracheal tube places some pressure on the region where the saccules have been excised and helps to control some of the hemorrhage, and then go on and do their nares after that, and then obviously extubate them slowly. I think the other thing from an anesthetic monitoring standpoint in brachycephalic dogs that have had BOAS is that their resting end-tidal CO2 is much higher than a normal dog. So they've been living life, some of them, with an end-tidal CO2 on a daily basis of 50 millimeters of mercury, for example. And so don't be surprised if your brachycephalic patient under anesthesia is ticking along nicely with kind of a higher than normal end-tidal CO2. We usually try and keep dogs at around sort of 40 to 45 millimeters of mercury. But some of your brachycephalic patients, it'll be hard to get their CO2 lower just because they've equilibrated. And you may find that it takes a higher level of end-tidal CO2 to stimulate them to breathe. So most dogs have the respiratory drive is primarily from the end-tidal CO2, but in brachycephalic patients, expect to kind of stimulate them to breathe as you're waking them up.
So as you're saying that if they've got a bit of post-induction apnea or they're just not breathing, not to stress as much as in, because you need that end-tidal a bit higher to stimulate the breathing, is that?
Yeah, so you may need to, if your patient has stopped breathing while they're under anesthesia and you've been ventilating them, it may take a little bit longer, and you may need to let that end-tidal CO2 get a little bit higher than than you would be comfortable with in a non-brachycephalic patient in order to stimulate their respiratory center to get them breathing again.
But things have weird physiological responses to actually getting room air into their lungs.
Right.
Actually normal amounts of oxygen. Like, what the hell's happening? What's all this oxygen? Where's it coming from? All right. And then that post-op period, first of all, the setup. And obviously, Brian, you work in specialist clinics, so I presume you're going to have a full 24-hour team in most of the hospitals there taking care of them. If you're in a clinic, well, let's ask it this way, Mark. What's your setup with these guys? Do they always stay 24 hours post-op? Do you have to have 24-hour monitoring to do these safely at all?
Yeah, good question, Bronwyn. You and I guess our clinics will differ on this, and we're not a 24-hour clinic. Again, we see a lot of young or 8 to 12-month-old dogs. If we have healthy dogs come in and have a pretty straightforward BOAS procedure where they don't have any concerns, they're home that afternoon. If it's let's say the dog needed a track tube placed, then again, really depends on the dog, depends on the owners. There's a lot of factors that come into play, but obviously if it's a high risk and we have 5 minutes down the road an emergency centre,
okay, cool,
and we have a relationship with which they offer what we call babysits, which can vary from a babysit that's literally just keeping an eye on it all the way upwards. So, knowing what to look for, knowing what's a concern, what's not a concern, having them 5 minutes next to an emergency centre should things go wrong. Okay. We think sometimes, and Bronwyn, you can comment on this, is especially high stress dogs that have needed a track tube, yes, keeping them in hospital gets us to have our eyes on them, but sometimes the hospital environment can stress them out itself. Yeah. So we find getting them home early, and we usually when we send them home, we have the owner in the room with them, seeing them for a few hours before we send them home, just to see how they go with it. And we think actually that reduces risk, and sometimes that can reduce the dog's need to be in hospital for longer because they're at home, they're comfortable in their environment. And again, that's all on the assumption that everyone knows what they're doing, everyone's comfortable, the dog's comfortable. There's a lot of things that need to be ticked off, but that's our post-op care. We don't have a 24-hour. We don't routinely recommend it unless cases are appropriate for it. But
you have easy availability to 24 hours. I think that's the key thing. So I'm trying to imagine if you're a small country practice and you're not 24 hours and there's no emergency center, should you be doing these? Probably send them somewhere where they can be watched potentially overnight.
Mm-hmm. Yeah, I think, again, we see slightly different populations. I think it's totally feasible that, otherwise healthy young dog with very mild clinical signs that has surgery at, finishes surgery at 10 a.m. could conceivably go home at 6 p.m. and be fine, providing that they haven't had any post-operative issues. I can completely see that could be reasonable if they've had a very straightforward procedure. I think the majority of cases that I see, at least, are fairly clinical by the time they've come to me. And so I don't think I've ever sent one home the day of surgery, mainly because we do have 24-hour hospital monitoring, and every surgery patient in our hospital stays overnight for intravenous pain relief and post-op monitoring. One thing I would say about having these patients in your ICU or in your hospital is that they need to be in the post-operative period somewhere where they're easily visible. So it's pretty easy for these guys to silently obstruct and die, and you wouldn't even notice if you didn't have somebody actually in that room actually watching the patient really actively, and it's very tragic when that happens. So I think having them in a kennel that's easily seen from the computer station, for example, is really important. If a patient needs a tracheostomy tube, I would say as a absolute rule that I would never send a patient home with a tracheostomy tube in place. I think by default, if they've had to have a trach tube placed, then their upper respiratory tract is probably, if not completely obstructed, at very high risk of being completely obstructed. And so if that trach tube slips or becomes blocked, the patient is going to, their respiratory tract is going to obstruct and they'll die pretty quickly. And I would say that they would die within 5 minutes. So you don't have, if that happens, you don't have 5 minutes to get them to the emergency center. And I think unless the owners are themselves veterinarians, it's very difficult. I don't think owners should be attempting to replace a tracheostomy tube that's fallen out or become blocked or anything like that. And so I guess I would say that if your patient has had that kind of a complication post-op, then my strong advice would be that patient should go to the 24-hour center for overnight monitoring.
Okay, so are we missing anything in that post-op period from either of you? Any other inputs or anything? But I think we've covered it pretty well. Or is there something?
I think one question I had for you, Mark, and was when when do you feed these patients post-operatively, or at what point in the
good
post-op period do you tell owners that they should feed them, and what do you feed them?
Yeah. Usually the next day we'll feed. That night, depends on the level of interest, but slowly, really small amounts. And we go soft food. So that can be whether that's like chunks of meat or whether that's canned food. Obviously, having airway work done is going to have that inflammation. So we always say not dry food, nothing hard that's going to be abrasive. But we usually...
Bones?
Again,
what about bones? Can they have bones?
No, not for it. Certainly in that period, we kind of say for the first 5 to 7 days is our point where we stay on a wet, soft food that's going to allow nothing to go down and scratch where the stitches or depending what's been done. But yeah, we try and feed them pretty soon afterwards, assuming they want to eat. And then by 10 to 14 days afterwards, because we do our checkup at 10 to 14 days, it's our first checkup. At that stage, assuming things are going well, they transition back onto their normal dry food. Are you similar to that? Are you different?
Yeah, pretty similar. I tend to hold off food until the morning after surgery, and then I'll put on the treatment sheet that I would like to feed them myself. So I'll hand feed them just a couple of meatballs. So we form soft food's important, and also soft food that can be easily swallowed whole as a bolus. So the goal is to not have food getting stuck on the stitches. So rather than giving them a bowl full of soft food, I'll put the soft food into kind of meatball. And you want to be watching the dog swallowing carefully, just to make sure that they are swallowing and separating their breathing from their swallowing that first meal. And then after that, feeding frequent small meals of meatballs. And I'll ask the owners to hand feed them for the first couple of days in that same way, and then switch to soft foods for a week or two, and then back to the normal food. But I think what you want to avoid is morning after surgery with your probably quite hungry bulldog, giving them a huge plate of food, kibbles or any sort of food that they sort of stick their head into and choke or aspirate, because they're trying to work out how those pharyngeal muscles and swallowing is coordinated again. So
I love that tip of the little meatballs. I can also imagine, if you're always the one feeding them, that those dogs must love Dr. Bronwyn when they come in for their checkups. They're like, "Hey, it's Meatball Girl."
I think it's more that I just want to see. I just want to see them swallow. Make sure that everything looks good.
Makes you sleep better.
Yeah, exactly. It's sort of reassuring. Yeah.
And I was going to say, I think also in that post-op period, more and more I'm finding that the first week, a lot of them do have, if anything, like an increase in maybe some regurgitation or a bit here and there in the first week, but usually it's by 10 to 14 days post-op, especially with the snoring. Sometimes they're a bit louder. And we always talk about with our owners that expect a little bit more snoring, because it's those expectations that you set, where if they think my dog the next day is going to be silent and no regurgitation, they start regurgitating 5 times a day and snoring, well, they're going to be concerned. So it's setting those expectations, and we find that they're still kind of regurging more sometimes, just because you've got stitches in there, you've got airway inflammation, but usually it's a 10 to 14 day mark where they're like, the first week was rough, and that's where they start to see the benefits, and they actually start to see. And then usually between that 2 week to 3 month post-op is when they start to exercise them. So most people say, I haven't exercised yet. And then we kind of get an idea of the benefits in the exercise tolerance noise kind of area.
Okay, is that us? I think we're done. That was great. That's super, super insightful. I love that. There's a lot of advice there for the referring vet, even if you're not the one doing the surgery, setting these up right and then wrapping them up nicely. That's perfect. And then for the next episode, we will talk about the surgery a little bit more, about the actual detail of surgery, what gets done, just so everybody has a better understanding of what actually happens when you're in there, and also talking about how to assess the respiratory tract for surgery if you're not the surgeon, getting these checked out and deciding whether you should send them off or not. Hopefully everybody enjoyed that, and we'll join you next time. Thanks again, Brian and Mark.
Thanks very much. It's my pleasure.
You know those conversations that you have at conferences, back in the days when we still had big vet conferences, when people are chatting to the lecturers and asking questions, and you hear things like, "This isn't really in the books, but here's what I think." It's in those kinds of conversations that the best nuggets of wisdom appear, the nitty-gritty real-life details that you can only get from years and years of experience. And it's exactly those kinds of conversations that we try to emulate on the Vet Vault Clinical Podcasts. We don't want lectures. We want to hear about the challenges, the tips, the stuff-ups, this is how I do it. go to vvn.supercast.tech to join in the conversation.